Let me invite Dr. Muralidhar Pai, Dean, Sikkim Manipal Institute of Medical Sciences, Professor of Obstetrics and Gynecology, on the topic, Is ART an answer for RPL?
Yeah. Very good morning to all of you. First of all, congratulations, Dr. Jayakrishnan, for doing this continuously for 25 years. And for inviting me, thank you very much. Of this 25 years, many times you have invited me. And I'm really thankful to you for calling me on 25th anniversary of this. So let me start this by narrating a small anecdote that's recently happened in my own college. What happened one morning, one senior professor in our medical college came to my room and said, "Sir, I want to discuss some private personal issues." I said, is he trying to become parent now? Because he's quite senior person. Then he said, no, I wanted to discuss about my daughter's issues. She's in America. And straight away, he's put an allegation. He said, I didn't know that in America also, the infertility specialists are out to make money like in India by unnecessarily prescribing IVF. I was taken aback. When he was a little bit agitated and he was a little furious also. I said, what is it, sir? So then he said, see, my daughter never had problems with conceiving. And they are now advising IVF for her. Immediately I knew what was coming up. She had 3 abortions, consecutive abortions, recurrent pregnancy loss. And then, of course, with the discussion, I came to know that there was definitely a problem with the parental chromosomes, and rightly so, they had advised ART. But you can imagine, even a senior professor in a medical college does not understand this. When we straight away advise IVF for the lay people for recurrent pregnancy loss, they are going to ask the same question to us first. I don't have problem with conception. Why are you advising me IVF? So that's where this talk is placed. So I will put it as RPL is art and answer, or I can just twist it because I had given similar lecture somewhere else, said what are the options for unexplained RPL. Now that unexplained is a really tricky terminology because it is not explained here. It may be explained somewhere else. It is not explained in this couple, but it may be explained in some other couple. So this is the barrier that we have. Unexplained is not really unexplained. It can be unexplored, I should put it as. So when we dig further, then we realize there are other problems that actually have to be tackled. That's where I will put it as, first, let us understand what are the definitive causes, which are undisputed causes. There are so many causes of RPL, but of them, these 2 are really undisputed. There's no question about these causing RPL. Number 1 is chromosomal abnormality, that is parental. Yes, earlier we used to say the chromosomes play a very small role in RPL. Yes, in a stray abortion, it is up to 70%, the chromosome problem, but in a recurrent pregnancy loss, it is less than 3%. But then the problem is, these 3% people will definitely have RPL every time they conceive. So that is why chromosomal abnormality is a definite cause of RPL in those who have this problem. I want to clarify that. Second one is acquired thrombophilia. All of us know about that. I'm not going to talk detail about RPL. I'll concentrate myself on chromosomal problems which are to be really addressed by ART. There's no other way. The significant proportion of RPL is associated with structural or numerical chromosomal abnormalities such as aneuploidy, mosaicism, translocations, inversion, deletion, or fragile sites. Increased risk in first-degree relatives. It may be related to shared HLA types, coagulation defects, immune dysfunction, or other identified heritable factors. The chromosomal rearrangements are to be looked for. This is very important because 3 to 5% of couples with RPL, that is 0.7% of the general population, have a major chromosomal rearrangement or what we call translocations. In that, balanced is very important. In that, reciprocal contributes 60%, Robertsonian contributes 40%. The carriers of 13 to 14 translocations have at least some chance of successful pregnancy because the risk is only 25%. But the carriers of 22 to 22 translocations will always miscarry. This is very, very important for us to understand. And inversions, of course, we all know. That's exactly why ISHRE 2022 guidelines, if you see, parental karyotyping could be carried out after individual assessment of risk for diagnostic purposes. There's again a confusion whether to carry out the karyotyping of the abortus or whether to carry out on the parents. Abortus is only helpful in telling what was the cause last time. It may not repeat or it may repeat. It will repeat, as I said again, if there is a balanced translocation between the couple. They are, in a sense, truly made for each other couple in a way. They both, it's very, very rare to have both the parties to have this kind of a translocation. So what is important here, they have said parental genetic testing, association, yes, contributing factor, yes, prognosis, yes, but what is the treatment? They have said treatment is PGT. This is where IVF is required. We cannot do this if we allow them to have natural pregnancy. The couple will say, I can conceive, but I cannot take out the embryo and I cannot do the PGT. This is what is very important. Suppose they are not willing for anything, then adoption, or you can ask for a donor gametes, both sides, or other alternatives have to be explored. This is very, very clear now as far as the RPL due to chromosomal problem is concerned. So in fact, I can stop my talk here itself, but I'll go little more on this. The karyotype abnormality, the treatment is referred to genetic counseling, but what they can do in a natural pregnancy is only prenatal genetic studies such as amniocentesis or chorionic villus sampling to determine the fetal karyotype. And what can you do? If there is a problem, you have to advise MTP only. So that doesn't solve our problem. That's exactly why we cannot allow them to again and again conceive on their own. Peri-implantation genetic test can be used. This can avoid transferring and implantation of an affected embryo. That's where ART is definitely a solution for RPL where there is chromosomal issue. So gamete donation, egg or sperm, surrogacy and adoption. Surrogacy is another thing they will not understand again. Okay, I can understand ART, but why surrogacy? Again, some of the implantation issues are related to the chromosomal issues also. So surrogacy is again advocated, and adoption are methods of preventing conception of an affected embryo. This is again ISHRE guideline 2022. Let's look little elaborately on IVF and PGT. Embryos of women with unexplained RPL have higher incidence of aneuploidy for chromosomes 13, 16, 18, 21, 22. And I have already talked about 22. 22 is 100% RPL all the time. X and Y than embryos obtained from healthy women. However, studies evaluating the value of IVF and PGT in women with unexplained RPL have yielded mixed results. Again, this is as happens in IVF of any situation. Even if the patient didn't have RPL, we know that the results are not always 100%. The patient thinks that, okay, I'll agree for IVF. Can you guarantee me a pregnancy? That we cannot guarantee. That goes with the IVF results. That's what it is meant. Now, what is the reason for oocyte donation? Poor quality oocytes may be responsible for 25% of unexplained RPL. This is not just the chromosomal problem, poor quality embryos also. Then that is due to oocytes. Womb donation has been associated with the live birth rate 88% of the time. Here, again, little difficult to explain to the patient. They will easily understand chromosomal problems. But this one, they don't understand. What is the quality of egg? Why should I have enough eggs? I am young. They don't understand why there should be a egg donation. So this is the reason for that. The success of womb donation, even when the male partner sperm is utilized, suggests that absence of a significant paternal contribution to RPL. So again, usually the professor was the father of a daughter. They do not want to blame themselves or their daughter. They will always say, maybe there is some problem with my son-in-law. That's always the thought. Okay, so this is clear that paternal contribution is very little, although now they are exploring more into male factors. Unfortunately, it's most of the time it's a problem with the eggs. Surrogacy. Let me explain this. I was telling a little bit in the earlier slides. Again, the patient will have difficulty in understanding why surrogacy. I have uterus, I have everything. Why surrogacy? Surrogacy because it is considered in women with RPL or recurrent IVF implantation failures. So we all know as infertility specialists, we have now almost conquered the the fertilization in vitro. It's 100% success, almost. But implantation is the real thing which we have to crack. Recurrent embryonic aneuploidies may be one of the reasons for that. Again, we go back to the aneuploidies. Obvious intrinsic gamete factors, that is single gene defects, diminished oocyte and embryo quality. We all the time blame the uterus, uterus, uterus. But this could be uterus plus the embryo. That's exactly where surrogacy might help, because certain of these issues may not be compatible with her own uterus or endometrium. It may be compatible with other endometrium. So the good news for people with unexplained RPL is that the chance of live birth is very good. Over 50% with no intervention also sometimes. So I'm going to the second part of my talk, the unexplained RPL. What are the possible treatment options? Of course, lifestyle modification has entered into every field of medicine. Here also can increase the fertility potential, although these have not been definitively tested by RCTs. Eliminating use of tobacco products, alcohol and caffeine definitely have contributed to successful pregnancies. Reduction in body mass index, we all know even 5% decrease in the body mass index makes a lot of difference. What about aspirin? Now all the treatments of unexplained RPL as well as infertility sometimes is going towards how to improve the endometrium and how to improve the implantation, and whole lot of drugs have been utilized. Number one is aspirin in that, because this we have learned from the cardiologist, it will dilate the vessels. So what is the literature say? Trials have reported that aspirin does not improve live birth rate of women with unexplained RPL. It may improve the blood flow, it may improve everything else, but that's not all. That's what we have to understand. It will definitely have positive results in terms of what it has to do. But what we want is a successful pregnancy. That unfortunately has not happened. Again, low molecular weight heparin. This is another attempt to improve the blood circulation in that area. Also, they found out the new role for low molecular weight heparin. It promotes trophoblastic invasion, which we want for the remodeling of the vessels. It inhibits trophoblastic apoptosis and restores placental HCG production and alters cellular immune responses. All this in addition to its antithrombotic property. But again, trials show no benefit to LMWH treatment in women without an inherited thrombophilia. If there is no problem, unnecessarily wasting, these are injections, these are expensive injections. They have to be given on a long term, at least for 3 months. So we should not do that. What about HCG? This has been our favorite. HCG and progesterone has been our favorite. We try to do it. Again, the usual logic used is, there's no harm in using it anyway. This is the usual logic in all of the medicines. HCG, to date, there is insufficient evidence to recommend the use of HCG to prevent pregnancy loss in unexplained RPL. Large randomized control trials are needed. That's the usual sentence in every research. What about immunotherapy? Because yesterday we heard Dr. Pillai talking about immunotherapy, making it inroads in cancer therapy. So what about immunotherapy? Yes, the Cochrane review says systemic reviews have consistently found no beneficial effect of immunotherapy in unexplained RPL. People have been trying. Now progesterone, I have put really biggest possible font because this has been the debate in every single conference and everybody. I am talking about progesterone in unexplained RPL, not the recognized LPD. Again, LPD is a big question mark. We don't know how to diagnose LPD. We don't know how to treat LPD, but somehow we give something, and especially the progesterone, in different routes, and that clicks. Now, I'm talking only about progesterone in unexplained RPL. We all know about this PROMISE trial, which told us very clearly the progesterone supplements in the first trimester of pregnancy do not improve the outcomes, right? But the people who produce progesterones, they don't stop. You know what they did? They said, okay, what they used was a wrong progesterone, oral progesterone. Now you have to use luteal vaginal micronized 400 mg Q12 hours cell maximum 4 times a day, and you do it up to 28 weeks. Okay, don't stop at 3 months and all that. So, and they came up with this fantastic paper, and they said more effective than placebo in reducing the risk of miscarriages if administered in the luteal phase of the cycle in women with history of unexplained RPL. But you know what? This paper had to be retracted. This is the biggest shame for any researcher. If you have to retract an article, that means you are influenced by the company to sell this. So this article was retracted in March 2020. So let's not fall into the trap of any of this. Let us understand the subject properly and let us do things properly. The ethical way is the best way. In the long run, that's what will save you. What about TLC? Of course, whether it is in terms of modified lifestyle or whether tender loving care, give in plenty. I was talking about male factor. Yes, now people are exploring. Maybe male also has to be blamed. Why can't we blame him? Why should we blame all the time females? RPL has long been considered an issue stemming exclusively from female causes. If a man achieved pregnancy, his gametes were deemed to be normal. That's how always, we always think if he has produced a child, that is normal. But it can later change also. But female factors only account for 50 to 60% of RPL, leaving 40 to 50% unexplained. That's unexplained maybe the males. Possible male factors have not been satisfactorily addressed to taken into account in these numbers. So that's why ISRE 2022 says, if in couples with RPL, it is recommended to assess lifestyle factors in male partners. Paternal age. Of course, a 94-year-old man can produce children. But what kind of gametes will be there? There will be a lot of problems. There will be a lot of mutations. That may be the reason for RPL. Smoking, alcohol, consumption, exercise pattern and body weight. So body weight of men is also very important, not just the females. So what they say is it requires further clarification, and as far as treatment is concerned, changing lifestyle, and for couples having ICSI, the use of hyaluronan selection looks promising. Further studies are needed to confirm this. So I would like to conclude what are the clear-cut messages that we have now is no immunotherapy. It's a grade 1A evidence. So let's not try that anymore. No glucocorticoids, grade 1B. No progesterone for unexplained RPL. Let me clarify again. Grade 1B. Start with simple, low risk and less expensive interventions. If unsuccessful, move on to more complex, higher risk and expensive options like IVF, PGT, egg donation and surrogacy. Thank you so much.
Thank you so much, Doctor, for your valuable insights.